Okay, so our presentation is over improving patient experience in the IU Methodist Emergency Department. I'm Gianna Gandolfo.
I'm Lindsay Benson.
I'm Anna Wiggum.
I'm Georgia Horn.
I'm Ashley Kramer.
Emily Lewis.
Keely Stafford.
Hannah Morris.
Abby Large.
Let's put ourselves in our patient's shoes. Imagine you go to the emergency department expecting urgent care and knowing what's going on. But unfortunately, you're left with a lot of questions. When am I getting my pain medicine? Where are my lab results? Am I gonna get admitted today? Where's the doctor? I haven't seen my nurse. A lot of patients reported that they felt left in the dark when it came to communication with providers and nurses at IU Methodist.
65% of the patients that come into the emergency department are eventually admitted to an inpatient unit. Based on previous data collected, patients at IU Methodist rate their experience in the emergency department 10 points lower on satisfaction surveys than if they were to be admitted directly inpatient. This gap, if left unaddressed, can cause significant consequences, including decreased patient retention, financial losses, reputational damage, and most importantly, poor patient outcomes. This semester, we partnered with the Experience Design team at IU Methodist. This team is dedicated to improving patient experience and satisfaction. Our primary collaborators included BT Stuck, the team's director, Carly Temple, and Jake Hartmeister, both senior consultants on the Experience Design team. So now we're gonna move on to the assessment.
Our SMART goal is that the emergency department at IU Methodist will increase their Net Promoter Score from 29.8 to 38.6 by January 2026. And this will be 1 year after our interventions are implemented.
For our background information, about 80,000 patients are seen annually at IU Methodist, making it the busiest hospital in the state. Sometimes we can see patients boarded up in the unit for up to 2 days before they get admitted. Every discharge patient is sent a patient experience survey, and their responses are what directly impact the patient satisfaction ratings, as well as their recommendations to others for that unit. When we consider stakeholders, this includes ED hospital staff, so that's nurses, techs, providers, hospitalists, EVS, anyone that interacts with the patients, as well as the patient and any of their loved ones. And what this is costing the unit is decreased profitability overall. So looking at business case, negative patient experiences lead to complaints, lack of referrals, and decreased compliance overall. When we can turn these bad patient experiences into good patient experiences, we see statistics that show that there's a higher proportion of elective patients, that there's an increase in revenue, which includes net patient revenue and lower costs. And then as hospitals are able to be financially stable, we then see that they're able to maintain highly reliable systems and be able to provide for quality improvement projects. And next, we're going to talk about our analyzed portion of the project.
Okay, so this is basically a very rough outline of what it looks like whenever a patient comes into the ED, whether that's by ambulance, they drove themselves, whatever. They go in, have their wait time, they're triaged, then they get seen by a doctor and a nurse. They may have some lab results or blood drawn, pain control, medication, stuff like that, and then they're either admitted to the floor or discharged. So this is the current process flow map for how that currently goes in the hospital. As far as our data collection methods, our patient population was patients in the ED that were going to be admitted to a med-surg floor, specifically floors 4 and 7, or patients currently on the med-surg floor who were admitted from the ED. So basically, whenever we would go in, we would either go in as individuals or in pairs. We'd do knock, hand hygiene, introduce ourselves, and then we'd ask them questions like, how did you get here? How long have you been here? How would you rate your stay on an experience of 0 to 5, 5 being the best, and just kind of get a sense of their overall story, so that way we could compile the data.
So when we initially met with Methodist, they told us that they wanted to collect all of our data via journey mapping, and this is the example that they sent us to base ours off of. So this is something completely new to them, completely new to us, but it essentially just breaks down the visit into everything along the way versus just one overall score, 4 to 10 or however. So the first half of the journey map is essentially what Keely just said with the process flow map, and then it it goes down into their emotions during the whole stay to see what Methodist is already doing well so that they can keep that the same, and then see where they're not performing as well so that they can try to fix that, and then it goes down into the gains and pain points and how they can improve. So since we did a journey map on all of the patients that we interviewed, that'd be a lot of data for us to cover with you guys. So we're just doing one example of a good experience journey map. So this patient rated their experience a 10 out of 10. They felt like Methodist was really good at making them feel safe, saw them in a timely manner once they were admitted or once they were in their ED room. Had good pain control. There was good nurse to patient communication. However, the long waiting time to get into the emergency room and then a long wait time for the inpatient room were the only negative ones they had. But the patient was understanding that it's the emergency room, it's kind of hard, like if you don't have beds, you don't have beds, so they didn't knock them any points and gave them a 10 out of 10. For our example of the floor score, this patient rated them a 4 out of 10. They thought the pain control was good once everyone was on the same page. However, there was poor provider communication about needing a direct admit. There was poor provider to nurse communication about pain control. There's poor nurse to provider patient communication because the patient felt like they weren't taking their concerns seriously. They felt like they had to advocate for themselves and they just weren't feeling heard. So the opportunity areas for this would be communication across the board.
So we had an IU patient experience guest speaker a few weeks ago that talked about net promoter scores. I'm just going to kind of touch on it. There's a 0 to 10 recommendation scale that they send out in their survey. And then you kind of rank what category they are based on their answer. So 0 to 6, detractors, 7 and 8 are passives, and 9 and 10 are promoters. And that's how you get your net promoter score is your percent of promoters minus your detractors. So this is what we're calling our stoplight chart. This is from patients that we interviewed and kind of what their main complaints were. Obviously, you're seeing a lot of communication and wait time for the 1 and 2 most common complaints. And then you're seeing privacy and pain management are a lot of detractors. So that might be like the big ones to hit on too.
So this is our fishbone diagram that we made that kind of shows how after we've interviewed all our patients, these are our 6 things that kind of cause the most people to give us a lower score, 1, 2, 3. So the biggest thing that we noticed, as we told you earlier, is communication between really anyone in the hospital, mostly nurse to patient or provider to patient, that caused most detriment to our scores. And now we're gonna talk about the plan.
So because communication is our main focus, we came up with 3 interventions. The first one is to improve and or kind of implement using Vital ER advisor accessibility. Make Vital ER more accessible, to everyone. So we're gonna put posters regarding the use of Vital ER advisor in every patient room, and then also in the waiting room, so they can figure out how to download that and use it prior to going into the room. We're also going to focus on the communication between the provider and the patient, and we would hope in the new ER, if we can't fix it in the current ER, but that providers will be sitting closer to patients within 6 weeks of implementation, and then also improving the provider to nurse communication. This would include the providers utilizing EHR to alert the nurses of any immediate changes, and then also making sure that they have daily interprofessional huddles within 1 week of implementation.
So since communication is such a big topic, to go kind of more into detail about why we chose these interventions, we chose communication and we broke it down into different professional communication like aspects. So with provider to patient, we decided that providers are often located far away from patients and nurses. So just moving them to like how nurses have nursing stations, to have a provider station right next to them so that that communication can be more quick and efficient, and have patients and nurses have easier access to these providers. It'll help facilitate that more communication to the nurses and to the patients so that patients don't feel like they're left in the dark and nurses aren't waiting on this information to come from providers. And then with provider to nurse, this is often where a lot of the problem comes to be, because nurses are that front line who are supposed to be bringing that communication to patients. But a lot of times nurses don't really know what step in the process we're at, or they're busy and they have other patients. So we thought that utilizing the electronic health records by either having some sort of notification or having doctors being able to secure chat or message the nurses to make sure that any new changes or orders are immediately alerted to them. The standard should be that nurses should be promptly informed of any changes in treatment plans or orders so that they can inform their patients of these changes. We also thought that another great idea would be regular collaborations or huddles between the interprofessional teams, which this just allows for those check-ins and making sure that these priority patients are being seen quicker. And also we're just making sure that the provider, nurses, everyone on the care team is on the same page so that we can communicate this information to the patients. But the one we really chose to focus on is Vital ER Advisor, and Anna will go into more information about that.
So Vital ER Advisor is a patient experience platform designed to walk patients through every step of the emergency department. It runs off of their cell phone number that is collected and entered into the electronic health record upon their arrival at the emergency department. And we're basically, to complement this platform that they already use right now in the emergency department, we designed these posters to help patients better understand their journey throughout the emergency department. So the poster basically just provides clear and accessible information about Vital ER Advisor and how to use it, how to get set up with it when you get there. So by displaying these posters, we hope to ensure that patients are better understanding their journey throughout the emergency department and also feel empowered to take an active role in their own care. And additionally, these posters will serve as a helpful aid to the emergency department staff, enhancing the communication with their patients and also avoiding repetitive questions about the emergency department. And this is what it looks like.
So with the implementation of this Vital ER Advisor, it will change the process flow map just a little bit. So currently with Vital ER Advisor, it's being explained at the front desk, the check-in desk. And we noticed that this is probably a high anxiety time for patients where they're trying to get into the emergency department. They're not probably focusing on this information that's being thrown at them. So we wanted to create a way for them to reiterate that information without having to stress out our nurses by telling the same kind of story 10 times to every patient. So that's why we created this poster. So first in triage, we'll explain the Vital ER Advisor at the desk, which is currently being done. And then when they give their phone number at admission, it'll send a text message to their phone with a link to the Vital ER Advisor. And then they will go into the rooms and they will see our deliverable, that poster. And that has all the information on how to access Vital ER Advisor. It makes it very accessible, very clear cut how to use it. And then if there are any questions, it'll be explained by the nursing staff so they can educate them on what this tool is and how it works. And then finally, the patients will have access to it and it'll eliminate a lot of those questions on what are we waiting on, because that is what this website offers. It kind of breaks down why there are wait times and what possible things are backing up the process. And then we'll go into test and implement.
So the people that we need to have us help implement this are the emergency department unit manager and the unit educator. Those people are involved in updating the team on changes and the kind of things we need to do to improve patient satisfaction scores. So these people need to make sure that these posters are present in the room and patients know that it's for them to see and use. And we need to also make sure that every time a patient checks in that they're getting their phone number taken. So since this involves just having a poster and this is already a process that's kind of in place, we would like to anticipate a start date of January 2025. So this is sort of a step-by-step plan on how we're going to implement it. So it involves making the poster, putting it up, and making sure that it's in places that people can see it. We can't really implement this change without instructing providers and nurses to encourage the use of it, even though it might seem cumbersome at first. And then we need to follow up with patients regarding the usefulness so we know that this intervention is actually worthwhile and worth the effort.
When looking at breaking down our budget, we did design a poster, but IU Health might have a more specific format that they're looking for. So in order to develop a poster that fits their criteria, they might need to hire a graphic designer, and that would be around $300. Then they'll have to print the posters. We were thinking a larger size, kind of like an 18 by 24, so that it really pops and the patient is drawn to it rather than just a simple sheet of paper. And professional printing for all of these posters will cost around $500. And then we'll educate the staff on how to use Vital ER Advisor and what these posters say and how to point the patients to them. And this will be about $35 an hour per nurse. And we thought it would take only about an hour to educate on this poster since it is a pretty straightforward process. Then I have a more thorough budget breakdown. So it includes the developing the poster, printing the poster, and educating the staff, like I mentioned previously. But then we also want to make sure that this intervention is actually working. So we're going to have to do some remodeling on current electrical or electronic surveys that they have right now, that patient experience survey. And so in order to modify this, we were going to add a question to it. So that'll take just a little bit of an IT role in that. And then we were also needing to analyze how often this Vital ER Advisor is being used. And again, that's going to be an IT or a nurse role to look and audit that. So I talked about collecting data to measure that this intervention is working, and how are we going to do that? So first, we are thinking about adding that question to the patient satisfaction survey that's already being sent out for every patient that is discharged. The question that we're thinking about adding is, how useful was Vital ER Advisor? Just a scale of 1 to 10, and having that not available if they weren't informed on how to use it or didn't have access to it. And then we also want to analyze the trends of how many people are actually using Vital ER Advisor. So just a way to see how many patients are clicking through that link rather than just receiving it. And then we were thinking for the first quarter that we're going to complete these audits monthly so that we're able to make sure it's working right when we implement it. And then after this first quarter, we would review it quarterly, since at this point in time it's been implemented well, hopefully. And we'll address any low values as needed throughout that process. And how are we going to spread this intervention? We are thinking about implementing it into the other nearby IU facilities, which include IU Arnett, University, IU North, IU West, and IU White. Just the same poster. They all are using the Vital ER Advisor, so it's just an extra step in the process. And then IU is currently building a new hospital site that will replace University and Methodist, and that will be open in 2027. So we want to make sure that this is carried into that new hospital site. And then we'll go into the impact and conclusion.
So, in conclusion, just to restate our SMART goal, we hope that the emergency department at IU Methodist will increase their Net Promoter Score from 29.8 to 38.6 by January 2026, which again is 1 year after we plan to implement our changes. And then we're going to meet this goal by improving communication between the provider and the patient, the provider and the nurse, and making Vital ER more accessible to patients. And this is going to impact Methodist alone by increasing patient retention. Hopefully they know exactly what's happening the entire time they're in the ER. It's going to decrease financial consequences, and then it'll build a better reputation for Methodist. Just by hopefully improving the communication will improve the Net Promoter Score, which again will make people want to come back if they do need to, and then it'll improve patient outcomes.
Thank you.